Good morning, everybody. My name is Tom van der Pol. I'm from the Amsterdam University Medical Centers in Amsterdam, the Netherlands. And my talk's about macrophage activation-like syndrome in sepsis. Let me start by saying that I do not have any conflicts of interest. Pediatrics has known a syndrome that's named primary hemophagocytic lymphohistiocytosis for a fairly long time. This is a genetic disease of impaired perforin-dependent cytotoxic function, resulting in a life-threatening hyperinflammatory syndrome, mainly driven by excessive release of pro-inflammatory cytokines. There's also a secondary form of this syndrome, which has been named also macrophage activation syndrome, or MAS, which can present at any age, including in adults, and which can be triggered by a variety of medical conditions, including infection, and in particular viral infections, hematological malignancies, and autoimmune and autoinflammatory disorders. There are several diagnostic criteria for both primary hemophagocytic lymphohistiocytosis and the secondary form macrophage activation syndrome, and this table summarizes some of these diagnostic criteria. These diagnostic criteria consist of both clinical parameters, such as fever, hepatomegaly, and splenomegaly, but also a variety of laboratory conditions, which are also summarized here. And these are not strictly the same in the primary syndrome and in secondary syndromes such as MAS. So you see on the left-hand side the primary criteria, and then on the two right panels, scores that have been used to diagnose the secondary form. The laboratory values rely for a large part on DIC, disseminated intravascular coagulation, as indicated by hypofibrinogenemia, and also hepatobiliary dysfunction, as indicated by disturbed liver function tests. High ferritin levels, which is important for the remainder of this talk, are also a diagnostic criterion for both the primary and the secondary form of this syndrome. And finally, for the primary syndrome, a bone marrow biopsy is required to show hemophagocytosis. And obviously in the secondary form, macrophage activation syndrome, this is not always available. So this is not mandatory for the diagnostic criteria. The relevance for macrophage activation syndrome for sepsis has been illustrated by a recent retrospective analysis of a trial in patients with sepsis, septic shock and severe sepsis that evaluated anakinra, which is interleukin-1 receptor antagonist, for efficacy in reducing mortality in these patients. The original trial was published a long time ago in the early 90s and did not show a survival benefit. However, in a recent performed retrospective analysis, when patients were stratified into those with evidence of the macrophage activation syndrome, as indicated by hepatobiliary dysfunction and disseminated intravascular coagulation, and into patients that did not have evidence for macrophage activation syndrome, it was clear that in those with evidence, there was a strong survival benefit of those treated with interleukin-1 receptor antagonist, with a survival increase, as is shown on this slide, which was very significant. The Hellenic Sepsis Study Group, led by Evangelos Gemellelos Bourboulis, took this a little bit further and looked at the incidence of what they called macrophage activation-like syndrome in sepsis. And they called it activation-like syndrome because there were no bone marrow biopsies available. So they said, well, we cannot strictly adhere to the diagnostic criteria of the primary syndrome of macrophage activation syndrome. So they used the H score that was also listed on the table a few slides ago, and they looked at hepatobiliary dysfunction and disseminated intravascular coagulation criteria and found an incidence of 3 to 4% in patients with sepsis admitted to the ICU in Greece. And this was both tested in a test cohort and a validation cohort. It was also shown that the presence of macrophage activation-like syndrome was independently associated with an enhanced risk for 10-day mortality. So the risk was approximately twofold when the criteria for MELS, for macrophage activation-like syndrome, were fulfilled. And this group next looked at the value of plasma ferritin levels, which is part of the diagnostic criteria of macrophage activation syndrome, as a standalone diagnostic marker for the presence of this syndrome. And they came up with a cutoff value of 4,420 nanograms per milliliter. And this cutoff value was associated with a very high specificity and a non-predictive value of the presence and absence of MELS. So patients who were below this cutoff value were very unlikely to have macrophage activation-like syndrome. Then the Hellenic Sepsis Study Group further looked at the relation between this cutoff value of ferritin and survival. And this is 28-day survival for sepsis in 3 independent cohorts, a test cohort, validation cohort, and a second validation cohort. And the lower curves with the red indicated MELS is always indicating those patients with macrophage activation-like syndrome, and they clearly have a reduced survival when compared to patients with sepsis that do not have these very high ferritin levels. These very high ferritin levels, so the cutoff of over 4,000 nanograms per mil, was also associated with enhanced pro-inflammatory cytokine release, as shown here by IL-6, IL-18, and interferon gamma. Now, it's important to realize that the Hellenic Sepsis Group, together with the Nijmegen group from the Netherlands, put a lot of value into this cutoff value of ferritin in 4,400 nanograms per milliliter in the design of a sepsis trial. So this is an overview of the pathogenesis of sepsis, with on the top panel in red pro-inflammatory responses implicated in the pathogenesis of sepsis, and in the lower panel immune suppressive reactions implicated in the pathogenesis of sepsis, and these are in blue. Now, most of the interventional trials that we have been doing in the past decades sought to interfere with the pro-inflammatory response. And as you know, all of these studies, like anti-TNF and also interleukin-1 receptor antagonists, were negative. Now, what the Hellenic Sepsis Group proposes is to use ferritin as a biomarker for macrophage activation-like syndrome, and then select patients based on this biomarker for anti-inflammatory therapy. And this is what we call predictive enrichment of the study population. So by using ferritin as a biomarker and this cutoff, they will be seeking to enrich the population for patients that are more likely to benefit from an anti-inflammatory strategy, such as interleukin-1 receptor antagonist. And in fact, Evangelos Giamarellos-Bourboulis, together with Mihai Netea from Nijmegen, performed a so-called PROVIDE study, in which they stratified patients with sepsis for treatment with either interleukin-1 receptor antagonist or an immune stimulant, interferon gamma, based on ferritin level. So patients with a very high ferritin level, the cutoff that I've been talking about before, were stratified to interleukin-1 receptor antagonist. And we're awaiting the results of this trial that was recently completed. We also looked a little bit at the meaning of having such a highly elevated ferritin level in patients with community-acquired pneumonia admitted to the ICU. And this is a study done by Xante Brands and Floris de Vries in my own laboratory, looking at 153 critically ill ICU patients with community-acquired pneumonia. And approximately 10% of those patients fulfilled the criteria of macrophage activation-like syndrome based on very high ferritin levels in the cutoff used also by Mihai Netea and Evangelos. Next is the stratification, CAP-MELS, so patients with macrophage activation-like syndrome and those without. And clearly you can see that patients with MELS have a higher disease severity, as indicated by acute physiology scores and SOFA scores, and also enhanced proportion of shock. Hematological malignancies were overrepresented in the patients with MELS, and the odds are close to 7 that you have MELS when you have an hematological malignancy on board. Mortality was reduced, was enhanced, increased in patients with CAP-MELS relative to CAP controls. This is illustrated in this slide. And we also looked at pathophysiological pathways implicated in the pathogenesis of sepsis, to which extent they were disturbed in those patients that were stratified based on the biomarker cutoff proposed in the PROVIDE trial. Not surprisingly, perhaps, patients with macrophage activation-like syndrome had enhanced pro-inflammatory cytokine release, but they also had a more disturbed endothelial cell function and also more endothelial injury, as indicated here by thrombomodulin, Syndecan, and the ratio between angiopoietin-1 and angiopoietin-2. So they had more glycocalyx disruption and more barrier dysfunction and also more injury. And also they had more coagulation activation, as indicated by D-dimer, lower platelet counts, and increased activated partial thromboplastin time. We also asked the question in less severely ill patients hospitalized with community-acquired pneumonia, what hyperferritinemia means. So if you have ferritin levels above normal. And in red, you see patients that were admitted to the hospital with CAP, and approximately 50% of them have elevated levels of ferritin relative to control subjects, which are depicted in blue. And also in this less severely ill population, modestly elevated ferritin levels are associated with a disturbed endothelial cell function, again as measured by Syndecan and angiopoietin-2-1 ratio, glycocalyx integrity, and barrier integrity. These patients also had more extensive coagulation activation, as indicated by D-dimer levels and platelets. So ferritin, not only these very high ferritin levels indicating macrophage activation-like syndrome, but also modestly activated hyperferritin levels may be of value in identifying patients with a more disturbed procoagulant response. So in summary, what I've told you, macrophage activation-like syndrome occurs in a small subgroup of sepsis patients, 4 to 10% approximately, that ferritin and very high ferritin levels may be a very good surrogate marker for the presence of macrophage activation-like syndrome. MELS is not only associated with enhanced pro-inflammatory cytokine release, but also involves endothelial cell dysfunction and a more extensive coagulation activation. And finally, the identification of this syndrome may assist in the selection of patients that are more likely to benefit from anti-inflammatory therapies such as anakinra, interleukin-1 receptor antagonist, and this is what we call predictive enrichment of study populations in sepsis trials. I thank you very much for your attention.